Aloha from RWCS 2018. My name's Mahadevan. I'm a gastroenterologist at UCSF. This year at RWCS, I covered 3 different topics. The first topic was how to direct refer a patient for colonoscopy. Many rheumatologists will want to send a patient to the gastroenterologist due to access issues. Sometimes it's easier just to get them in directly for the procedure they need. But before you send someone in, what are the things you need to think of? In your patient population, do they need to stop their aspirin and NSAIDs? If they're on blood thinners, including warfarin, heparin, or even the newer agents that are antiplatelet agents, do they need to be stopped? And the answer often is yes. And a lot of that has to do with their risk factors and whether they need bridging therapy. All of this information needs to be shared with the gastroenterologist. If you're taking care of a patient with ankylosing spondylitis, are they safe for conscious sedation or do they need an anesthesiologist present? The more information you put in your referral, the easier it is to get your patient in quickly for the procedure that they need. The second topic that we covered is small intestinal bacterial overgrowth, or SIBO. This is very common in all populations, but particularly as patients age and as they're on various immunosuppressions and proton pump inhibitors. SIBO is an overgrowth of bacteria or dysbiosis leading to bloating, gas, and discomfort. For many patients, this requires a visit to the gastroenterologist, but you can take care of it yourself in many occasions. You don't always have to get testing, as it can be inaccurate, but if your patient meets the description of SIBO, you can give them a trial of rifaximin 550 milligrams 3 times a day for 10 to 14 days and follow that with probiotics to see if their symptoms resolve. Dietary therapy such as a low FODMAP diet can be helpful as well. Finally, we finished with a review of updates in inflammatory bowel disease. Rheumatology patients and IBD patients have a lot of overlap. We use many of the same drugs. And in addition to the anti-TNF agents, we also have anti-integrin agents such as vedolizumab, which has been very effective. There's been a lot of talk that vedolizumab is gut-specific and therefore does not help with rheumatologic or spondyloarthropathy complications of patients with IBD. However, if you treat the underlying bowel disease, in many cases their arthralgias will resolve. Also, tofacitinib will be under consideration by the FDA in March of 2018 for approval for ulcerative colitis. So that will be yet another drug that we will share. Thank you, and for more information, go to rheumnow.com.